Hello, everyone. We are waiting for everyone to enter the virtual room. Meanwhile, I'm gonna present myself. I am Clémentine Schilt. I'm the head of digital education at Institut Pasteur. And today we are here with Laurie Pinault. Laurie Pinault is the community manager of your MOOC. And Jean-Pierre Vartagnan is the director of the MOOC. And Pascal Pinault is today with him to answer your questions. We'll start with the questions that were asked in advance. Laurie, the floor is yours.
Okay, so good afternoon, everyone. So as Clémentine just said, so I'm the community manager and I've been sending you the regular emails for this MOOC. Okay, so as Clémentine said, we just gathered all the questions you asked in the registration form for this MOOC, plus some additional questions that were on the forum. So we will start with human papillomaviruses. So there were quite a few questions there. So actually, we're going to start with the first one, which was redirected at the early proteins E6 and E7. And you were asking if these proteins could be blocked through human medications, through therapeutics.
Yes, in fact, both of us are not specialists of papilloma viruses, although Jean-Pierre has worked on it a bit. So I will do a kind of general answer to this first question. There is currently no medication patented and on the market used to block the activity of E6 and E7. But of course, as it is major oncogenic protein, there is trials, there is a different approach that are currently studied, and it can be vaccine directed against E6 and E7 in cancer patients. So it is curative vaccines. It is not preventive vaccines. It is different from the usual anti-HPV vaccine. There is a second approach. It is CAR T cells, or an immunotherapy based on the culture of T lymphocyte targeted against papilloma virus that could be educated to trigger an immune response once they are re-injected in patients. There is a third approach against E6, E7, and it is more like, let's say, for the future, it is an approach based on the enzyme, the modification of DNA with TALEN, CRISPR-Cas, different kind of DNA modifying enzyme capable to target integrated HPV genome and remove it from the cells. It is the third approach. There is a fourth approach that is based on that is a bit old-fashioned. That one, it is based on the use of some chemical compound like curcumine, berberine, but it is as you can see, it is old compound, so it is not something according to me that might yield really groundbreaking results. So that a bit. All I can see. There is also maybe another approach. It will be use of small molecule like antisense RNA or microRNA, but all the approaches I have mentioned in my answer are related to trials. It is not bona fide therapeutic that are currently used in routine medical practice. It is research.
Thank you, Pascal. Another person was asking if you could describe a bit more how do vaccines, current licensed vaccines against HPV work?
You want to answer?
In fact, the vaccine against papillomaviruses are a little bit special. You know, in the course, when you analyze the virus, there is late genes and early genes. as Pascal said, for example, E6 and E7 are early genes, and L1, L2 are late genes. So in fact, an L, it's for late, and there is the capsid that it's surrounding the virus. This virus has no envelope, and it's we use the capsid protein to make this vaccine, and in fact, it's pseudo viral particles. So the L1 proteins mimic the virus, but there is no DNA inside. It's just the protein which is surrounding the particle is just L1 proteins. It's concatemer of proteins which mimic the virus. And then when you inject that, it's recognized as a virus, but there is no side inside. There is no DNA inside, and then the immune system can make adaptive immunity against this vaccine. And when you are infected, then you have this immunity which is in place and can shut down the virus which are coming in the body.
Thank you. Is it necessary to continue screening for oncogenic papillomaviruses beyond 65 years old?
So I'm not a clinician, but what I know, it is that the answer is not yes or no. The answer is it depends. Once a lady reached 65 years old, if she has been tested in the decades before with always negative test, pap smears or PCR DNA, PCR reaction, amplification of HPV, and everything has been negative in several tests in the decade before 65 years old, it is not recommended, it is not mandatory to continue the screening for papillomavirus infection. On the contrary, for the ladies who have previously been submitted to diagnostic test and with diagnosed cervical intraepithelial neoplasia or positive test by PCR, anything positive, yes, these ladies should continue to benefit from monitoring of by their gynecologist for monitoring of the cervix to check whether there is a progression or if it stay healthy. So again, no black and white answer. It depends on the context before 65 years old.
Merci. And the last question regarding human papillomaviruses, is there viremia during HPV infection? And if so, in which biological compartment?
So normally there is no viremia during papillomavirus infection if we are talking about cervix infection, because it is an infection of an epithelium that is shedding the particle outside around the cervix and in the vagina of the woman. So it is not going in the reverse direction. It is not entering in the bloodstream. Nevertheless, when you have a cancer that is developing, there is integrated DNA of papillomavirus, HPV 16, 18, etc., the high-risk one. And these cancer cells with integrated DNA are, for some of them, killed by the immune system, immune cells, and the content, the DNA content of these cells is shed in the bloodstream of the patients. And then you can retrieve using a really sensitive PCR like droplet digital PCR, you can retrieve HPV DNA in the circulation of the patient, in the free circulating tumor DNA, FCT DNA. And I think that our colleague that is giving a lecture here in Pasteur, Hélène Perret, working at the Hôpital Européen Georges Pompidou, is monitoring the level of HPV DNA in the patient who have been submitted to therapeutics or surgery with removal of the tumor, and to check whether everything is clean and there is no remaining infected cells. She is measuring by a digital droplet the level of papillomavirus DNA in the free circulating DNA in the plasma. It is in the plasma. The compartment is the plasma.
And something interesting to know also, it's that 100% of cervix cancer is associated with a papillomavirus, a high-risk papillomavirus. There is almost nothing cervix cancer without papillomavirus. High-risk papillomavirus is papillomavirus 18 or 16 or 18. This is an important point to know.
Thank you. So let's move to hepatitis B and C viruses. So there were quite a few questions on those. So the first one was, is it possible to contract hepatitis B or C from transfusion and then have the infection remains silent for decades until it leads ultimately to liver cancer?
Yes, it is possible to be infected through transfusion, blood transfusion, although it became more and more infrequent. It is maybe one case every 10 million. It is a really unlucky situation. Before, it was not the case. In the 70s, before the discovery of hepatitis C, many people were contaminated through transfusion. But now, all blood donation are tested for the presence of anti-HCV and HCV RNA if they found anti-HCV. Therefore, there is the risk is considerably lower than it was several decades ago, and it is the same for hepatitis B virus. Because hepatitis B virus was discovered in the 60s by Baruch Blumberg, and then a battery of tests has been developed to test the blood donation for the presence of HBV, and now it is molecular test, mostly nucleic acid test detection that are used to check for the presence of hepatitis B virus in the blood of the patient. But it is costly. It is not practiced in every country. There is a region of the world with low and middle income country, but mostly low income country, where they are not doing systematically this test, and it remains a residual risk of hepatitis B transmission in some region of the world, but it is less and less frequent than it used to be.
Thank you. Someone else was asking if family members of hepatocellular carcinoma patients should undergo screening for these viruses.
Yes, they should. Hepatitis B is easily transmitted in a horizontal way within a family, because hepatitis B is present in saliva, it is present in every human secretion, and it is very stable. So the newborns and the children, toddlers, are contaminated by HBV quite easily. And yes, if there is hepatocellular carcinoma due to HBV in a family, it is a good policy to check all the remaining members of the family, the different generation living in the same household, for the presence of hepatitis B virus, not hepatocellular carcinoma. Hepatocellular carcinoma, it is the end of the road. Yeah. For hepatitis C, yes, I think that there is. I think that usually the husband and the wife are tested, but I don't know whether it is all the family, including children, are tested for anti-HCV or HCV RNA, because HCV is not so easy to transmit. Usually it is transmitted through parenteral routes, injection or scarification or a breakage of the skin. So the family, if a member of a family develop an hepatocellular carcinoma with the hepatitis virus, HBV or HCV, yes, it is generally a good policy to investigate other member of the family within the same household to know whether the virus has spread in the family or not.
Another question regarding these viruses was to know if HBV and HCV are the only viruses with the liver tropism that can induce hepatocellular carcinoma, or are there other viruses that can infect the liver and also result in HCC later on?
The answer is not black and white as well. There is 5 hepatitis virus, A, B, C, Delta, D, and E. Only B and C are considered as bona fide liver carcinogens. However, hepatitis delta, it is a viroid, it is a parasite of HBV, and when it is present with HBV, generally the risk to develop an hepatocellular carcinoma becomes higher. It is increasing the risk of liver disease progression, either through the cirrhotic way or through the carcinoma way. So hepatitis delta, it is a co-oncogenic virus. It is not bona fide standing alone oncogenic virus. And for the hepatitis A and E viruses, they are responsible for acute infections, and therefore they are not associated at all with an oncogenic process.
Okay.
That's my answer.
Thanks. The last questions regarding HBV and HCV that was asked in advance was regarding the patients that were cured, who were cured from HCV with direct-acting anti-HCV drugs. Do fibrosis biomarkers allow to identify patients who are the most at risk for HCC development after the cure? Or are there other biomarkers that could be used to kind of predict the cured patients who would be at risk for HCC?
So the story, it is that with the age of the direct antivirals used to wipe out the hepatitis C virus infection in patients, the medical doctors and their patients believe that the life will be happy and there will be no bad news regarding an evolution, an unexpected evolution of the chronic liver disease. But it was maybe a naive way to consider the situation like that, as people who were clear from hepatitis C virus, anyhow, for some of them, unlucky, will develop an hepatocellular carcinoma because the hepatitis C lasted for so long, for 3 or 4 decades, that in the liver of this patient, there is cells that have been modified with mutation or epigenetic change that are responsible, that make them susceptible for the development of an hepatocellular carcinoma. So in the patient who have sustained infection for decades, but now are free from any active hepatitis C infection, the risk is there. And for this patient, there is a monitoring. if this patient have a fibrotic liver. Fibrotic liver is a major sign, a major predictive sign of future hepatocellular carcinoma development. If this patient have a fibrotic liver, as measured by liver stiffness using the FibroScan device, a device that is sending waves on the liver of the patient and that is measuring the degree of fibrosis or the degree of steatosis, I mean the stiffness, if the stiffness is high, this patient should continue to be monitored by the medical doctors in their tertiary centers. But there is FibroScan, liver stiffness is important, but it is not always present in the facility where patients are living. So there is also the usual standard method used to monitor chronic disease, and it is measurement of aminotransferase, ALT, AST. It is measurement of alpha-fetoprotein. It is surveillance of bilirubin, platelets, and albumin. All the cells and products that presence or absence or variation are related to the global health of the liver tissue. So yes, of course, patients without who have been cured for hepatitis C should be monitored with these approaches.
Thank you. So we are done with the questions so far for HBV and HCV. So we can move to the next virus that was mentioned in questions, was the human T lymphotropic virus 1. And there was a question regarding the high anti-HDL1 antibodies in mothers that would favor virus transmission to children, and what is the mechanism behind this? And also another factor that was associated with HDL1 acquisition from infected mothers for children was genetic factors. So what are these genetic factors? So a bit more insights into these different factors that favor the infection of a child from a mother.
Yes, I will give, I'm not Antoine Gessin, I am not Philippe Aponceau. So I will try to give true but quite generalist answers to these two questions. First, concerning antibodies. In fact, to my knowledge, there is no facilitating antibodies that facilitate the infection of the cells. That, as it happens with coronaviral infection, not maybe COVID-19, SARS-CoV-2, but with some coronaviruses infecting cats, for example, responsible from visceral infection in cats and killing infection. There is that kind of antibody facilitating transmission, infection of the virus. It is not the case with HTLV, to my knowledge. In fact, the level of antibodies is just a translation of the level of infection. And if there is more infection, more transmission from a mother to a newborn during feeding by milk, by breast milk of the baby, if there is more transmission, when there is high level of antibody, I think that it is because there is a lot of proviruses present in the cells of the mother. And it is the cells of the mother that are transmitted through breastfeeding that will convey, that will be responsible of the infection of the baby. That's my generalist answer. For the second question that concern the genetic susceptibility, to my knowledge, there is no polymorphism, genetic traits that are associated with the development of HTLV infection or acute T leukemia, but there is some that have been linked to tropical spastic paraparesis. This is well known by Antoine Gessin, our colleague. There is some polymorphism associated with this particular disease, but with acute T leukemia or even with general susceptibility to HTLV-1 infection, to my knowledge, there is none. But I am not a specialist in the domain, and it is, of course, a moving field. What we can say that it is these infections are present in specific population in Central Africa, in pygmies, in living in the big forest, or they are present in the Ryukyu Island, south of Japan. And so I think the population who are susceptible to HTLV-1 or on which HTLV-1 is pushing its pressure, they are quite different genetically, Japan and pygmies. I think that it will be difficult to find commonalities and general susceptibility genes, but maybe I am wrong. That's my generalist answer.
Well, thanks for taking these questions, despite not being experts of the virus, as you said. So we'll obviously address these questions to Antoine Gessin, as you mentioned, and the other speakers who gave talks about HTLV-1. And if there are additional information, we will post them on the forum of the MOOC for all the learners to know more about these questions. But thank you. So after HTLV-1, there were quite a few questions on oncolytic viruses that was not particularly addressed in the MOOC, but still there were a lot of questions raised. So the live session is the opportunity to talk about this. So the first question was why these viruses can help for the treatment of cancer. So very broad question, and to understand a bit how they work.
In fact, I think that it's a real good strategy to use the oncolytic virus to treat some cancer, specific cancer. Why? Because in those cancers, in general, you have the upregulation of the receptor specific to the entry of the virus. I take the example, for example, in the Department of Virology, we have Frédéric Tangy, who is working with measles virus and is treating some cancer where you have the upregulation of SLAM, which is the receptor of the measles virus. And then this virus kills the cells because it replicates and is killing the cells. And there is two phenomena. When the virus enters in the cell, because it's lytic, is replicating and is killing the cells, and then you release some antigens from the cell that could be recognized by macrophages, dendritic cells, and then you stimulate the immune system. So the fact that the virus is oncolytic is going specifically in those tumors because you have the upregulation of specific receptors that are not present in other cells. So the virus is targeting specifically those cancers. And then you release the cells, release some different antigens from the tumors, and then it's recognized by different types of cells that induce the immune system.
Maybe there is a link then with the next questions that was to understand a bit more. Is there an immune response to these oncolytic viruses that's happening at the same time also, or?
In fact, it's not only the fact that the virus is oncolytic that you kill and you save the patients. You are not killing the tumors because it's just only the oncolytic activity. I think that it's both phenomena. What Frédéric demonstrated in the department, that in fact you have the fact that the measles virus, I take the example of measles virus, but there is different type of virus that can be used as oncolytic virus. Herpes simplex virus could be used, or picorna virus, or reovirus. There is adenoviruses also could be used as oncolytic virus. So the fact that you are killing the cells, the tumor cells by the virus, you release antigens that are recognized by the dendritic cells, macrophages, and then this is an inducer of T cells and CD8 and CD4 and B cells to produce innate or so of them it's adaptive immunity.
Okay, so the immune system responds to the lysis of the tumor cells, but not to the oncolytic viruses themselves. if I understand correctly.
Yes.
Um,
Or maybe the tumor antigens, no?
Yes, tumor. I think that the viral antigen that are produced by the tumor cells, because viruses are replicating within the tumor cells. I think that there is antigen that are maybe more easily recognized as non-self and new antigen by the immune system. So I mean, the cancer cell will be taken in kind of crossfire, as you say. They produce viral protein and will be killed because they produce viral protein, and they produce their antigen.
In fact, yes.
And they will be killed as well for two reasons.
If you take, for example, measles virus as oncolytic virus, we are all vaccinated against measles.
Yes.
So this is maybe a different aspect.
Yeah.
So it could be both, yes.
As you can see,
yes.
As you say, the Reoviridae, Newcastle virus.
Yes,
I mean, there is a lot of them.
And you still to modify a little bit your vector. Okay, maybe it's another questions with herpes simplex virus. I don't know, but you engineer the virus, then you change the properties of the virus also.
Okay. So I guess you answered a bit this question already, but just to clarify, do oncolytic viruses establish latency in tumor cells? Is there time for it, or do they kill the tumor cells so quickly that this is not happening? And do these oncolytic viruses replicate in nearby tissues, or where do they replicate in the end during this process?
In fact, they replicate in tumorogenic cells.
Okay.
But the problem is the resistance. Sometimes you can have resistance because in the tumor, the cells are heterogeneous, and then you can have probably sometimes resistance for many reasons. For example, if you have no receptors outside of the cells, the oncolytic virus cannot enter in the cells. But then the fact that the virus is replicating and this lies the cells, this will help to release proteins. So in fact, it's the oncolytic properties of the virus that can help to destroy some cells in the tumors. Probably not all, but maybe one day we can, I don't know.
And you just mentioned it, that there could be some resistance, and that was indeed the last question regarding oncolytic viruses, to know if tumor cells could indeed develop resistance to oncolytic viruses. So you just mentioned that if some cells do not have the receptors, then they are not.
Yes, this point, and also if they cannot stimulate also the immune system because they lost the properties to induce the immune system, and because you need both, in fact, to destroy the cells. It's not only the activity of the virus, it's also the activity of the human system. So if you have no signal to the human system to destroy the tumorogenic cells, it cannot be eliminate everything. So in fact, it's both. So you have many parameters, the heterogeneity of the cells, and loss of receptors, or loss of human selection, or not good replication capacity of the virus in the cells. The fitness is maybe low, it's different. Many parameters that avoid a good clearance or a good elimination of tumorogenic cells.
Thank you. Then we had additional questions that were no other topics. One was about VS virus. Could it be linked to cancer, and in particular to metastasis?
Which virus?
VSV.
Varicella
zoster virus.
Varicella zoster virus. You know something about VSV?
To my knowledge, but maybe you know better. To my knowledge, there is no link between varicella zoster and cancer. It's a reactivation, but it's not associated with cancer.
Mm-hmm.
There is only 2 herpes viruses which are linked with cancer, and was described in the MOOC is the Epstein-Barr virus, and it's the HHV8, which is linked with Kaposi sarcoma. So it's only these 2 viruses that have been described to be linked with cancer.
Yes, the question of the student was a bit specific because Laurie, you mentioned metastasis.
Yeah.
And so it's a bit a kind of another step in the progression of the tumor disease. And I don't know if varicella zoster virus.
In fact, if I understand the question, does it help to induce metastasis in the pre-existing?
Is there a link? Yeah.
For me, I don't know.
Neither.
Okay. And the last questions that was asked in advance is quite broad. Is like, would you have any online resources that you would recommend? So beyond the MOOC, to look for more definitions regarding all the topics that were addressed in the MOOC. So I don't know if there are other resources that you would recommend.
So I will say what I am doing myself. Myself, when I don't know something, I'm going on the NCBI bookshelf. It is a specific section on NCBI where there is a really serious textbook. And really, I'm doing that because looking for Wikipedia or that kind of thing, or even the artificial intelligence softwares now, it's a bit shallow. But if you want to learn a lot, you have to buy the FITS virology, and then you will have all the terminology and glossary and vocabulary available, but it costs some money. But the NCBI bookshelf, and I can give you the reference where I'm going. It is medical microbiology, section 2 virology. So for me, it is the most serious online resource that I know and that I'm using myself, but maybe there are others.
Jean-Pierre, would you have anything to add? Or...
No, he's right, but I wanted to say there is also the Pasteur course. This is beautiful if you have the opportunity to be registered in those courses, that you have a broad approach of everything, immunology, virology, biochemistry, chemistry, that everything is useful for understanding how virus could be linked with cancer. So I think courses and a book, and then you will be complete, I think.
So while we were, so it's over with the questions that were asked in advance, but while we were addressing them, there was one question that popped up in the Q&A. So it's regarding HPV. So the question is, can we use the standard cervical cancer HPV DNA swabs to also test for pharyngeal or anal infection with HPV? So I don't know if you have any answers to this question.
I think that it's the same virus. In fact, there is no different viruses. That it's like paraparesis spastic tropical and ATL. In fact, for H5N1 is the same virus. Is going to the nervous system, central nervous system, or in the blood. For those viruses, oropharyngeal, anal, or cervix cancer is the same virus. And if you are vaccinated, you will be protected against all pharyngeal, anal, cervix. So the vaccination will protect everything. So for answering to the question, I think yes, if you shut down by treatment that you have, for example, a cervix cancer, so you protect for everything. And this could be a control for checking all type of cancer correlated or associated with this high-risk papillomavirus.
The question was dealing with the technique to sample the virus, or?
And it's like using the standard cervical cancer HPV DNA swabs to also test for pharyngeal or anal infection with HPV. So I guess it's around the diagnostics.
Yes, I think we are not, both of us, doing routine medical sampling of papillomavirus, but I don't see why the medium the transportation medium that is used for cervix will not work for tonsil swabbing. So I think they can use it. They can use it.
Mm. There is another question that just popped up on the chat based for the oncolytic viruses. So Jean-Pierre, you used the example of measles. So for this example in particular, how does pre-existing immunity to measles affect the efficacy of the oncolytic property of this virus? And same question goes for instance, those based on herpes simplex virus.
No, I think that the immunity, the pre-existing immunity, of course, will help against the virus, and this will also be associated with the lysis of the virus. But then you make engineering of the virus also. You are not taking the wild type virus for making oncolytic virus. For example, the question you ask concerning the herpes simplex virus, that you have lytic virus and latent virus. Of course, we will not use the latent virus for treating cancer because the latent virus will not kill the cells, will not lyse the cells. So in fact, you engineer the virus to push the virus for being lytic. How you push the virus? By making mutations, using CRISPR-Cas9 technology to block some genes. For example, there is some genes in herpes simplex type 1 virus, which are called LAT, which are associated with latency. So you block those genes that you will push the virus for lytic virus. So you have, for example, in the laboratory have different type of viruses, herpes simplex type 1 virus, which are lytic viruses, latent viruses, and of course, you engineer the virus to push the virus to replicate and to be oncolytic.
But a way to avoid the pre-existing immune response is maybe the administration of the virus that could be injected directly in the tumor or in the vicinity of the tumor to reach immediately the cancer cells without wandering in the body and being trapped by the pre-existing antibodies.
I think I don't know exactly how they do the experiment, but I think that they inject, if it's easily, you can inject, you inject in the tumors. Otherwise, I don't know for glioblastoma, I don't know exactly how you do that when it's complicated to reach, maybe cervix cancer or breast cancer, because there is also treatment with oncolytic virus for breast, for blood cancer.
It exists for hepatocellular carcinoma as well.
Also, yes. So I think that it's probably directly on the tumors.
Yes, I think so.
Yeah, and because you have this upregulation of receptors, that is easy. So I don't know if you are injecting directly on the blood and if you circulate.
I don't think so. No. I don't think they will do a kind of infusion of virus in the general bloodstream. I think that the viral particles that are costly to produce, they will be injected under monitoring kind of spectroscopic technique directly in the vicinity of the tumor or in the main vessel that is going in the tumor.
But in fact, you need to engineer the oncolytic virus to get the best properties to kill the cells. This is, I think, probably the most complicated things. But as Pascal said, for the CAR T cells, it's another way, but you are making engineering also on cells from the patients to re-inject in the patients. So I think that the engineering process is maybe the most important step for making something very efficient for the treatment.
And then I guess as Pascal said, by injecting these oncolytic viruses, so the engineered viruses directly into the tumor, it's a kind of a way to escape any pre-existing immunity that can be there for the wild type viruses, non-engineered one. So I guess that answers one of the question that was in the chat. But we still have a few minutes in the live session. I don't know if Jean-Pierre or Pascal, there are other topics that you wanted to bring to the attention to the learners that are with us today?
The MOOC is very broad, so you go from fundamental to animal models to immunotherapies and all these different type of viruses which are associated with cancer. At least there is billions and billions of viruses on the biosphere, but there is only 7 viruses which are linked with cancer. So it's on the MOOC. But so far there is no other virus, because the question is, there is another virus that could be linked with cancer. And for example, we have discussed a lot of time with Pascal about the liver cancer, adenovirus, or at one time, I don't know if you remember, there is a retrovirus specific.
Yes, I remember.
So we debate many times, is this adenovirus or is this new virus could be linked with those cancer? But in fact, the answer is no. It's only those 7 viruses that have been really nicely discussed and described to be linked with cancer.
Yes, they are in fact this oncovirus, this oncogenic virus, are capable to trigger the beginning of the process. And that's why they are considered as oncogenic. But of course, we cannot say that other viruses, as mentioned, like the varicella zoster or hepatitis delta, that will come afterwards, after there is already a tumor process ongoing, maybe those viruses might play a role, might contribute, might facilitate tumor escape. But it is another story. It is not really oncogenic virus. It is comorbidities. It is oncogenicity, but it is not bona fide oncogenicity.
Because hepatitis delta, it's a defective virus.
Yes.
It cannot replicate on its own. It needs to have hepatitis B virus.
It needs. So its role will always be a question mark. Per se, it is not capable to trigger the tumor, it is believed. But it is, you know, there is a gray zone as well in virology. There is people with the disease of the liver, for example, can be infected in the liver by many other things. There is tropical viruses, dengue, Rift Valley, yellow fever, Lassa. All these viruses are going in the liver, and they are killing hepatocyte or endothelial cells. But they are not true hepatitis virus and true or oncogenic virus.
But do you think we might discover other oncogenic viruses in the future beyond the 7 that are already known, or it's a done deal and that's the definitive list of the 7 viruses that can induce cancer?
The problem is the barrier transmission between animals and humans. We see the flu from birds to pork to human, then you can create sometimes some very, very pathogenic viruses. There is the monkeypox that you know that the epidemics in May 22 in Africa, which was specific to animals, then spread outside of Africa in human species. So you have this transmission. So probably, I don't know if I'm pessimist, there is many oncogenic virus in animals. I don't know, many retroviruses. I don't know if one time we have this barrier jump and you go in humans and you change the polymorphism and you change, mutate, you adapt. It's a question of fitness, of mutations. Who knows?
I think it will be difficult because, except for the retroviruses, most of the oncogenic viruses, with the notable exception of hepatitis C, that is a mystery for me, they are DNA virus. And DNA virus, they are living in the host for a long time, for a million years, and they are well adapted to the host. That's why they are responsible for persistent and chronic infection that are at first unseen, that are translated in a disease after years or even decades. And for DNA viruses, it is more difficult to jump to cross the species barriers. It is not like for RNA viruses. And RNA, they are violent guys, replicating a lot, brutal, and they are ill-suited for tumor process, which are long and tedious step-by-step process into the deadly disease. So it's a matter of
in fact, we need also to understand that it's a fight between the cells and the virus. At the end, the virus is replicating. The virus doesn't like to replicate in tumorigenic cells. He wants something clean, not mutated, with a good metabolism. So at the end, when the cells switch toward tumorigenesis, of course, the virus did his job, but then he's leaving. So then, in fact, the cells win because the virus is gone, but they have a price to pay, is that the cells switch toward oncogenesis.
Yeah. Thank you. So I think, there are no more questions in the chat. I will just switch to this slide that depicts the timeline of the MOOC, and as it was written in the chat, you have I remind you that you have the exam opened from the 24th of June until July 8th. So we advise you to register before July 5th to avoid any problem in case you want to take this paid exam. I will still send you one email this week regarding the last chapter of the MOOC if you haven't followed it yet. And then I guess that's it. I don't know if Clémentine, if you want to add anything.
No, thank you very much. Thank you, Jean-Pierre, and thank you, Dr. Pinault, for this live session. It was really nice, and for the learners, I really advise you to take this first exam because then it's more difficult for us to follow you for the next exam that is in almost 1 year. Will be in 1 year.
Okay.
And so thank you, everyone. Thank you, Laurie.
Thank you.
Thank you. Bye, everyone.
Thank you, everyone. Thank you, Laurie. Thank you, Clémentine. Bye.